thank you so much for helping us to come and share our story today around where we are with the national piece of work around hearing checks for children with learning disabilities and autism. Jack and I have been working in this space for a little while now, but we've also obviously had those big pulls in other areas during the pandemic. But we were able to do something quite magical, I think, during the year where we were responding to critical care ventilators and COVID testing as a kind of secondment role. But I want to just give you an overview of what we're going to talk about today. First of all, the drivers for that innovation and how that sort of perfect storm enabled us to do something different. What it was that we did, the pre-pilot that helped us understand a feasibility project. And given the learning that we've had through the pandemic and the work that we've done, what are the next steps we have in this journey to understand how we get hearing checks for children in residential schools with learning disabilities and autism. Next slide. So we're very fortunate that we actually do have a line in the long-term plan, and I think earlier I sensed the frustrations of SEN not having a line in the long-term plan. And as an audiologist, this is the only line that contains anything to do with hearing. So just sort of one word more, but it makes all the difference when it comes to funding. And the long-term plan makes a commitment to bring hearing, sight and dental checks to children and young people with learning disabilities or autisms, or both, in special residential schools. And this is where we're starting our journey, is in the special residential school space. It doesn't mean that that's where it will end, but I think if we can get it right there, then we've got a good chance of rolling it out and getting it right across the system. Can we have the next slide, please? So I talked about this perfect storm, and it was in fact the impact of the pandemic. So I was identified as someone who could set up and lead the piece around hearing for that element of the long-term plan. And we held our first stakeholder event just before the pandemic kicked off. And so we had a lot of energy and a lot of goodwill and a lot of thoughts about how we should proceed, because it's not a routine thing that happens. And hearing checks isn't a routine thing that happens in normal schools either. It's very frustrating. So whilst we were seconded to work in different roles, it was always on my mind that there was still some workforce left in paediatric audiology that could help us understand this, and then the wider workforce out into the system around how we could get support and help for the work that we did. I was also working with an innovation that was an iPhone adapted to enable otoscopy, and that was part of the Clinical Entrepreneur Programme, and I've been part of that for a long time. It's a really jazzy bit of kit that looks less like a medical device and more like a smartphone. We had funding to do work, but the work we had planned couldn't happen because the schools were in lockdown. We weren't able to have access to them, and also we heard that a lot of the children had been sent home and were sitting at home, and so it made me think maybe we could do something more in the home. We were also hearing of how it was becoming more commonplace to be able to access patients and have conversations using the sort of digital e-health, telehealth, sort of super digital highway. So we combined all of these things and came up with a pre-pilot study. And Jack was working with me on another study as a fellowship around hearing, which was in care homes. And again, the same conditions applied where we weren't able to take that project forward. So whilst he's doing his fellowship in that space, he came across and helped lead this pre-pilot study he's going to share with you today. So over to you, Jack.
Thanks, Ruth. So let me just click onto my next slide. So as Ruth's just spoken about, a lot of the sort of drivers that really facilitated and enabled us to think outside the box. We worked with parent and carer advisors to really think about what was important for the parents and also the children. And as part of that, we identified that we wanted to look at 12 families or 12 children that had not previously tolerated ear checks within the clinical setting. The children had to have been diagnosed or under the diagnosis under diagnosis for learning disability or autism, and they had to be on the caseload for Guy's and St Thomas's. So these were children that were potentially coming back regularly because they hadn't previously tolerated the tests in that clinical setting. Ruth spoke a little bit about the innovation of the smartphone device, and the smartphone device, it was thought that this was sort of a familiar piece of equipment for parents to understand, and a lot of adults, they have smartphones these days, so we felt that would be a good facilitator. We'd also, as Ruth had spoken about, a little bit about the innovation previously, and we trained non-specialists to use this equipment, so we felt if we could train non-specialists to deliver ear checks, why could we not train parents? So as part of that, we developed some manuals in a step-by-step format to facilitate that training. We also developed a virtual training program using Attend Anywhere that we collaborated with Guy's and St Thomas's on, and their audiologists delivered the training virtually to the parents who had the equipment couriered to them, and they were able to use the equipment. We encouraged them to use the equipment and practice using the equipment on a relative or a friend within their sort of COVID bubble if possible, and then the audiologist could sort of advise them on how to use the kit and just make sure they were using it properly. Once the parents were comfortable with using the equipment, the parent delivered the ear check at home in a sort of a familiar environment for the children at a time that suited the child. And because of the innovation, the results were then able to be uploaded to a cloud where the audiologist could review the results from the clinic at Guy's and St Thomas's Hospital. So I'll talk to you a little bit now about the checks that we did. So you can see an image here of the smartphone otoscope. Now, an otoscope is a device that you can look in the ear with. As you can see, it's a smartphone, and we mentioned that you could record the sort of examination, if you like, and upload those results up to a cloud that meets all the sort of information governance and data standards for the NHS, and can be reviewed by the audiologist at St Thomas's Hospital. We spoke with our parent and family advisors about what they felt was important, and the parents advisors felt that it was important to rule out outer and also middle ear disease, so glue ear, any blockages of wax and so on and so forth, because often it was felt that children with learning disabilities and autism couldn't necessarily express that they may have had, or some children couldn't necessarily express that they were having difficulty hearing or they had pain in their ears. So ruling out glue ear as a first instance was really important. But we understood the limitations that not being able to test further and assess the sort of real sensory aspects of hearing. Another key figure around glue is that 80% of children will have glue ear at some point in their life. So if we could rule this out in a first instance, it would be a really good first step, always being aware of the limitations. So as part of the pre-pilot study, we developed a variety of resources. I spoke to you a little bit about the manuals. These were in a step-by-step sort of process that enabled the parents to almost check back and just reaffirm that they were happy with what they were doing. It talked them through processes of connecting the smartphone to the Wi-Fi, but also had a series of troubleshooting guides as well that they could go back to and have a look at when the audiologist wasn't available. But we also ensured that there was a contact telephone number and an email address so they could always get in touch if they had any issues. We developed a replica otoscope, so a replica device to look in the ear. This was to facilitate familiarization with the children, to ensure the children were prepared for the assessment that was coming on. So the device could be used for a variety of different reasons. For example, utilizing it for a role play to show the child that it wasn't, to show the children that it wasn't going to hurt, wasn't going to cause any distress. Could be used as a device to act as a distraction tool. It had a working light on it. And parents could also use the device to sort of practice holding the smartphone device without being concerned that they might drop it or anything like that. We developed social stories, again, to facilitate that familiarization and that preparedness for the children. And as I previously mentioned, we developed a virtual training program with the audiologist at Guy's and St Thomas's over Attend Anywhere that enabled the parents to really get used to the kit and ask questions if they needed to. So prior to starting the project, we asked parents about their motivations for taking part and also their emotions. I'll just pull out one of the key themes from the motivation section here. And we found that, they felt that there were quite a lot of barriers to accessing care. And those barriers included the environment. They felt that sort of a hospital environment wasn't necessarily the most appropriate environment for children and young people with a learning disability and autism. For example, the noises, the lights, sort of having to travel to the hospital and so on and so forth, resulted in children already being quite upset before they get into this, or some children already being quite upset before they get into the clinic room, making testing or checking more difficult. Similarly, sort of to unfamiliar environments, you have unfamiliar people and clinicians, and the parents felt that building that trust between the clinician and the child may sometimes be difficult. And that was related to the multiple appointment aspects, that sometimes children with complex needs have to come back for multiple appointments, and they may then associate hospitals or clinicians with trauma that they potentially previously had, or a not particularly nice experience where they may have had blood taking and so on and so forth. So all these sort of aspects came together, which meant that sometimes children would not tolerate testing. And linking that to the timing aspect is that, expecting children to tolerate a test when they had an appointment-based system as opposed to at a time that really suited the children. So this is what came out of our conversations with parents. So we were able to train the parents, and we asked them about their confidence before the training, at the end of the project, and we significantly increased parents' confidence at using both the device to look in the ear and also the pressure test to rule out blue ear. So outcomes from looking in the ear, we were able to significantly increase the number of children that tolerated an ear check, so someone looking in the ear, compared to a clinical setting when children hadn't previously tolerated checks in the hospital environment. And similarly with tympanometry, when we included the children that hadn't had tympanometry performed because they hadn't tolerated otoscopy, we found that there was a significant increase in the number of children tolerating checks in that home environment when the test was performed by their parent. So we spoke to parents after the project and pulled out some key themes from the interviews. They felt that trust was a key facilitator, that the children trusted them, the children felt that they weren't going to do them any harm, and that was a really important facilitator as part of that. But not only just the trust from the children, I think trust that they felt was placed in them from the hospital, from the clinicians, from the audiologists. It really empowered them, and they really enjoyed taking ownership of some of the testing. We found that familiarity and individualization was key, so ensuring that we had devices to facilitate preparedness and familiarity to the procedure, but ensuring that we had a variety of different familiarization techniques was important, because every child was different and would respond differently to a different technique, and so on and so forth. So making sure that individualized person-centered approach is taken. Another key facilitator, so we spoke about how environment and timing was a barrier within the hospital, but actually, conversely, when you're at home, those barriers become facilitators, because the environment is familiar, it's a safe place, and then you're able to take the opportunity to test your child when they're most comfortable or calm, and parents really felt that was key. And final sort of theme that was pulled out of it was the support they felt. So they felt the support was a key facilitator, that sort of partnership developed with the parents and the audiologist was really, really important. And they felt that all of the training and the manuals and the ability to get in contact was key, and making sure that this was a partnership, as I say, not just left to the parents to do on their own. So a summary of the pre-pilots, we were able to increase the number of children tolerating ear checks at home compared to in a clinical setting when they hadn't previously tolerated checks. Children were more comfortable at home and with the parent or carer performing the test. And we found that trust, familiarity and individualization was really key to ensuring that this was the success of some of the checks being performed. And parents really enjoyed taking ownership and felt trusted and empowered to perform the checks. Again, the sort of decision to do this should be the parents and no one else's, so we felt that was really important. So what are our next steps? So just bringing you back to the beginning around sort of the long-term plan, our vision is to ensure that we can provide equitable access to hearing checks, so ensuring that no child is left behind. Every child is able to access a hearing check, but we want to make sure that those checks aren't just performed for the sake of being performed, they actually contribute to improved outcomes. So if there is unmet need identified, we ensure that the support mechanisms are in place to support the children to ensure they get the right care and the right support they need. And as part of this, as part of developing this, we want to gain a consensus with a body of evidence to support this wider vision of good sensory health. So ensure that commissioning processes are in place to ensure that it continues to go on after the pilots and the proof of concept. So part of this, we want to remove barriers and ensure that every child gets access to a check, so no child is left behind. We want to ensure there is equity of access, so it's about what children can do and ensuring that every child, no matter what their preference is, can really get something that's meaningful or get a check that is meaningful. We aim to embed co-production within everything that we do and ensure that there's joint ownership and authentic engagement throughout the process with all stakeholders involved. And we've spoken a little bit about parents and taking ownership, but we want to ensure that we champion children, champion parents, champion the schools, and hope that they feel empowered to perform some of these checks themselves. So to ensure that this happens, we've got key structures within our program. So one key work stream looking at pilots and the clinical aspects that this kind of fell into. One that's looking at commissioning, ensuring that the program continues and ensure the mechanisms are in place to ensure that it continues after the proof of concept and the pilot phase, and then developing that evidence and best practice to support recommended procedures and ensure that the wider field support this process. So as I said, we want to ensure co-production is embedded. So we have partnered with the UCL Co-Production Collective to support the understanding of what a good hearing check may look like, understanding local landscape and developing innovation to support that sort of national learning, but also to ensure that all stakeholders involved, children, schools, parents, local authority, CCG, ICS, NHS are all included within that process moving forward. And as I said, to feed into that national learning to ensure we can develop that toolkit, that service model that ensures that it continues on. So in summary, we utilise trust as a conduit to perform a successful ear check. We're not saying that necessarily as part of the programme the parents perform checks, but there may be familiar people within the schools that may be able to support that process. Innovation meant that tests could be performed at home and the audiologist could remotely review the results. Parents were motivated to gain a greater understanding and to help others. These came out of our semi-structured interviews with the parents and to remove those barriers that they faced. As I said, we were able to significantly increase the number of children tolerating checks at home, and we're aware of the limitations of the number of children. The ability to form trust seems to be centred around ensuring the process, including the environment and the individual performing the test, is familiar for the child to reduce their anxiety. And we're looking to co-produce ways of delivering ear checks for children in residential schools so no child is left behind, and hopefully that learning will be able to move forward into other sectors as well. So I'll stop there. Thank you very much. Any questions at this point, and then we'll move on to the sort of questions what we hope to ask you. Shall I stop sharing? Hello?
Yeah, Jack, I'm here.
Hello.
Just waiting to see. So I see people are just sort of thinking, so just giving them a chance. I can see Kathy's got her hand up. You're still hot in conservatory there.
Yeah, that was really interesting. So I'm a paediatrician that does clinics in special schools, and I tend to see kids over a very long period of time, 10 years plus, and I find children let me look in their ears beautifully in the special school but won't for ENT. But is this the sort of thing that we could sort of do as part of our clinic as well, because it would save an appointment for the family, and if it's a child who's already familiar with us anyway, who happily lets us examine them, that it might be something that that could be built on in that sort of way as well.
So Kathy, that's the whole point of what we're doing, is we know that what's happened before with an audiologist coming in once a year is not the way forward. And so looking at the people that are in that trusted relationship space, whatever they are, where we know the barriers to access for that are less likely, I suppose. So yes, absolutely, I think that should go in the pot.
And how accurate is it? That was the other question. I mean, how does it correlate with what would be done in an audiology sort of setting?
So the ear checks themselves. Otoscopy is otoscopy, as you know, and if a clinician is able to view the image outside of the the environment, then we can check that. It's generally just to check for blockages or any sore or painful areas. The tympanometry is an objective test. By that I mean that you do need the child to participate in that. They need to stay still for about 3 seconds, but that's about it. That the results back from that test are do not rely on the child interacting or an interpretation. We are also thinking of doing another little test that happens, which is similar to the newborn hearing screen test, which is an otoacoustic emission, which tests a little bit further along the hearing pathway, and incorporating those 3, 2 of which don't require interpretation. The kit can tell you if it's a pass or fail sort of thing, or give you some diagnostic indicators. And I think the clue is that these are ear checks or hearing checks. They're not diagnostic tests. We're not presuming to deliver an audiology service in this space. We're just checking to see, because I think Jack's research shows that it's just not happening, and often has never happened because of diagnostic overshadowing, and it's the last thing people think of in terms of, and maybe hearing as well.
Yeah, just to add to that, from a perspective of the children not tolerate, I think if you look at the clinic setting, the Hummingbird Clinic at Guy's and St Thomas's, they've got quite high numbers of children that tolerate checks in their clinical setting. We did like a bit of an audit of 100 children, but these were specifically children that hadn't tolerated checks. So we're hoping that some of these processes potentially might be more favourable for children that were more sensitive to touch and so on. But yeah, definitely, if you're able to look in children's ears and gain that trust, then that sounds brilliant to us.
Any other questions?
There's a couple in the chat. So there's one from Kate, Ruth.
So Kate, who's going to carry out the checks? Well, I think if we just take the next steps on for sort of the next stage to help you understand, we don't know yet. What we plan to do next is build some workshops, so calling them sandpit events, but we've also been told that calling it a sandpit event gives the wrong message if children are coming, because they'll believe it is the sandpit event. So we need to look at reflective language to say what it does. So we're going out into every NHS England region. There's 7 in the country, holding 2 events that look at building pilot models and then putting those models in place in residential schools, gathering the evidence and working out how best we can actually deliver these 3 checks or anything else that people think we need to do. And then slowly, as we go around the country, building that up over the next 6 months to get an idea of what a good model might be. Currently, I believe, and Jack, with some training, the tests that we're talking about doing, or the checks we're talking about, can be delivered by someone with an element of training, but not a lot. And therefore it doesn't need, as long as we've got the pathways post-check in place to say, and if we think this needs further investigation, this needs to happen, then it's whoever the children and the schools feel is best, and parents feel is best to do that. And that's why we're doing this engagement process. So Kathy, I hope that answers the question to some degree. And then the next one is collaborated with TIGMA. So we're going to ask you some questions about that. But we meet weekly with the teeth and the eye people, and we hope that once we've probably in a year's time, it feels like a long time, but we've got a lot of work to do to just understand. But unlike some of the others, there isn't a model that exists that says this is the right way to do it. There's no recommended procedures. It's all a bit hit and miss, and audiology is locally commissioned, and then it's a mess. It's spread across health, social care, and education, where bits of funding sit in different places. So we're hoping over the year to build a more robust picture of what will work well, build the evidence base to persuade the system that this is the right way to go. But then we're certainly in conversation with the dental and the vision people to see where the synergies are and where we could collaborate as well. But we still just need to build that body of evidence before we get to that stage, so that we are secure within the sort of hearing world to be able to deliver that out.
Yeah. And just to add to that, I think that we want to ensure that it works for each local area. So working, as Ruth said, working with partners, it may be that in some schools there may be a speech and language therapist that is regularly involved with the children that might be best placed to do it. Or it may be that some schools feel that they've already got audiologists, for example, like yourself at the Seashell Trust, who might be best placed to do it. So it's really about engaging and co-producing it with partners, ensuring that we develop models that suit them. And from a perspective, from a checking perspective, and I think that it's developing strategies that enable that sort of no child's left behind, because not every child will tolerate an OAE, for example, which is an objective test, but they may tolerate something less invasive. So thinking about that toolkit approach and developing that further, but working with partners to do that.
So we've got some questions for you, if we can share those with you, so that we can really develop, make the most of your expertise in this space in the next sort of 10-15 minutes. And we know that this is going to video as well. So, all those people who are getting the popcorn ready to watch this tonight, we can capture their thoughts too. But there's a QR code on there. And if you don't feel like you want to verbally contribute, you can tell I'm used to working with scientific community. If you want to just individually respond or share these questions with, you think someone else might have some thinking for us, if you just hold your smartphone, if you've got one, up to the QR code on the screen now, that will take you to a form that you can fill out. Which will help us, which will ask you these questions, and it will collate all the evidence in on one form for us. Won't tell us who you are or anything, it'll just collate the information. So it's like you're going into a page and all writing stuff in there for us. So literally camera on your smartphone, hold it up against the QR, and it will appear at the top that you can just press on into the link. But our first question is this, and that is, what would you like to see included in a co-production event, develop equitable hearing checks or service models in residential special schools? So Jack and I and the UCL co-production collective, plus some other people, are going out into different regions. We're starting in the southeast of England because the vision and the dental people aren't there. So we're not exhausting the same experts with overload. So we're going into that bit of England first. And we've been told we can't go in over the summer holidays because people need a break from all of this. So we've got this wonderful opportunity now to plan our co-production event. And we want to make sure, so both Jack and I don't think we said this, are clinical audiologists by background. I'm SRO for this programme, but I'm scientific for London, and Jack is a clinical fellow in audiology, but a clinical fellow for this piece of work. And so when we go into these spaces, your expertise and your understanding of what a good event might look like would be really valuable. So does anyone want to start to add to that conversation, that we can start to pick it up? feel free to either put your hand up or just speak.
I was thinking about care staff in residential special schools who have a lot of time with the young people. I mean, obviously they're all on shifts and things, but care staff would be a big thing for me in that particular setting.
So actual the invite, yeah, okay. So if we were to hold an event that looked at how we could do it, actually inviting the staff who do the caring as opposed to the managers or the leaders, and get that's a good idea. That's a really good idea. We'll make sure we capture that.
I suppose that would be echoed in the special schools, wouldn't it?
Yeah, the TAs, the HLTAs, the ones who hands-on with the children, you know, they're the ones who are doing all that care, aren't they? That and the intimate care and all that side of things. So they're the ones who are going to have that relationship to build up the familiarity with equipment and all those things in a fun, safe way.
So tell me what we're not in your world. What does HLTA mean?
Oh, sorry, higher level teaching assistants. So those teaching assistants who are in classes and yeah, sorry.
Thank you, Alex. Kathy?
Yeah, I was just thinking about school nursing as well. I'm not so sure because we don't have any residential special schools in our area. We just have special schools. But, you know, the school nurses regularly see the young people for assessments as well. And it's just how it would tie into what they do, especially if they know monitoring growth at the same time, that there may be some opportunities there.
Thank you, Kathy. So I think there's a network of school nurses, I think, that we're hoping to dock into that can help support in that space. And the special residential schools, I think we've got a better chance of them having a school nurse than some of the other schools, to be fair. Maybe not. What do you think, Kathy?
I'm not sure they do, because I know that some of the children I see that go out to various schools, they don't have a school nurse. But every one of our special schools will have under the sort of public health school nursing offer or the community children's nursing team.
Okay.
They will all have the 0 to 19 public health service offer.
Okay, thank you. And then we're going to go on to our next question, which, Jack, if you've got power, you've got the power.
Yeah, there we go.
Okay, so it's the same QR code, so you don't need to take another photo of it. But if a hearing check was delivered in a residential school, what would you want to know and who would need to know about it? So first of all, given your, in your roles, if we go in and do a hearing check, who do we need to tell that we've done it, other than the school and the parent? Where's that data going to add value to the system? I think is probably that. So if we are starting to collect data around, you know, we've done 100 ear checks and these are the results, or we've done 100 ear checks, that's all you need to know because we've covered the whole population of the school. Is there anything there that you think we need to know about, or where the data should go?
It needs to go on either the local system 1, doesn't it? So that it's accessible to everybody.
And on the health record.
Yeah.
So
and I would say, I think the local authority who places the child there should know as well.
Local authorities.
The local authority.
So is there one central point where all the information around a child's health is kept and then kept up to date, given that quite a lot of children would travel, you know, maybe be out of borough or out of region for their residential school?
There is the system that local authorities use to ensure that every single child has got a file where all the information about them is kept. So there is always a single place.
Okay. And do you think GP should be informed as well?
Yeah.
Yeah, speaking from CCHAL's perspective, certainly when children and young people are, located somewhere away from where their home area is, I think the GP would generally be that central point. And I'm certainly thinking that sort of the local community therapy team, speech and language, occupational therapy, I think they'd really benefit from having the outcome of this.
Okay, that's really good to know as well. Also, if we required further referral for a child, so say you know, all the ear checks have been done and we've identified glue ear, and some people have not necessarily are not necessarily, they want to do a further investigation, what would the current referral routes be for children in special residential schools, or what would the desired referral be if we were able to put it in place for a child? Would it inform the parent and then the parent has to contact the GP, or we're trying to reduce the burden on the whole system of hoping that by just identifying that something needs to happen, how can we then make sure that it does happen?
Yeah, I'd say parents and GP. Certainly, you know, where we've got shared care arrangements, it would always be the parent that will be the central point of kind of liaison. We have children and young people who are 52-week-a-year placements, and often, you know, the registered manager, the care home manager would, you know, be the lead person in terms of liaising with relevant health professionals.
In terms of being able to refer on, so say a speech and language therapist needed to refer on to a more clinical space for, I don't know, maybe they needed to do some sort of scoping or something, would that referral need to come through the GP like normal referrals would do, or is there a space within children who are in a residential school for that to happen as an automatic with consent from parents? Or would it go via the GP?
In my experience, it would typically go via the GP.
Okay. I just wondered if there was a different referral route that happened. Because if a child fails their hearing screen at birth, they are referred directly on for further testing. And we're expecting to pick up some children who wouldn't have had that neonatal screen at birth. Or if someone fails a screen in a community setting, a school, so if you have a school nurse, quite often we can refer on to a sort of secondary space for further testing without going via the GP. Would that cause trouble, do you think, or would that be more streamlined?
I think that could be more streamlined as long as all the relevant key kind of stakeholders were kept in the loop.
Kathy, what do you think as a...
Yeah, it depends. It gets a bit complicated. It depends whether the GP's in the same CCG area as the people that you're referring to as well.
Yeah.
So it's a bit strange because I know as a paediatrician, we weren't allowed to do consultant to consultant referrals on, so we had to go back to the GP to get the GP to refer.
Yeah.
Which way it's all got very strange.
Yeah.
So it added in extra hoops for the child, and the GPs didn't really want to do it either. It caused them work.
Yeah. I think we're in a position, I'm like this, because I work in NHS England, to influence some of that commissioning decision making by the time we're ready where we are. So our commissioning recommendations from this pilot may look at some innovation in that space rather than just performing the routine ones, which is why this collaboration is really important. We're going to run out of time now.
Would that all work for looked after children that are in 52-week residential placements?
So we just, yeah, we don't know. We're just trying to work out what would work best and not be closed to thinking that we have to build a system that works with the current ways of working, and to be a bit innovative if we can, because nothing really exists that's joined up across the country in this.
So I think we probably need to come to an end there as we're at the end of our time. Is there anything else that you needed to...
We had a third question, but it's on the QR code. So if you do get a chance, just write in some thoughts, or if you can share the thinking on that QR code with colleagues, that would be really helpful. And thank you so much for helping us develop some thinking on this. And we will be coming to a region near you soon. Our emails are on there if you need to contact us. Thank you.
Thanks so much for listening.
Thank you.
So you have a 10-minute break now before your next workshop, which should be starting at 3:50.
Okay, and that'll be on this link.
For you, maybe, I think.
Jack, do you want to stay on? Because I'm not sure. I haven't got another link. I've only got this one.
I haven't got link yet.
Okay.
So
Perfect.
I'll stop recording now.